public partnership model has been very successful in Sindh, and if we look into this model, it could possibly be something which we can utilize, and other provinces can also utilize this model, which is solving some of the key issues and being able to administer the three pillars of the universal health coverage. So for the second round, we have identified all these problems, and I think we are all agreeing to it with all your expertise. We all know what the problem is. Now, if you can all just give us 2 to 3 solutions or recommendations, what should be the direction of working now in this time constraint of 5 years, trying to achieve universal health coverage through primary health care? Just 2, 3 recommendations from each one of you. Sir, aap se pehle.
Thank you. One thing I think we must keep in mind is that universal health care is not a luxury. It is right of every child that is born, irrespective of caste, creed, or pocket, or whatever. So far, whichever model you look at, private-public model in Sindh, this is not really a private-public model. It's more of a philanthropy-driven model. That you have people, because there are more industrialists in Karachi and in Sindh, and there are very, very rich people and too many poor people. So there are very good people who want to donate something to for the base of the pyramid. So that is being, I think, used. But if you go to the rural Sindh, which I have myself gone to rural Sindh many times, I think the coverage there is, nowhere near that we need to be. I think the universal health care in Punjab, they have tried to outsource it to the private, and they failed miserably. One thing the government must realize, or be made to realize, is that it is the responsibility of the government and not anybody else. So you cannot, provide universal health care or optimum health care to people with charity. Charity is add-on. You cannot shift your entire burden of your duties to the philanthropy center. You can only thank them for doing what they are. But they are not responsible. It's the government who is answerable to the people in what they have done. Unfortunately, I think what needs to be done is that we do have in Punjab, and I am in Sindh, rural health center, basic health units, but most of them are dysfunctional. They need to incentivize the human resource for health to go into these rural areas. Then they need to pay them double or maybe triple of that. So they need to populate that. Those buildings are now being used as, somebody has started a school there, or somebody. So they are not really functional at all, majority of them. So I think to make them functional, the main bottleneck is the human resource for health in these far-flung areas, the security issues, which again it's up to the government to sort out there, and then non-functional equipment there. So and then the provision of medicine is not there. So that needs a good governance model. In Punjab, we have a model where primary health care is separate and tertiary care is separate, specialized care. It didn't work. I think it was much better when we had one health department. The most important thing I think that needs to be done, and during my tenure as a minister, we started that, is the referral system. If you have a referral system where you have catchment areas with your tertiary care hospital, the teaching hospital, and then because they are also public sector organization, then give shift the this duties to them to make sure that there is adequate human resource for health, like for universities, medical universities, health universities, or for the medical colleges. We did a pilot where we attached few districts to a particular medical college, like Allama Iqbal Medical College, and then the consultants were going there weekly to the basic health units, and even surgeries were started and everything. But as always, once the government changes, everything changes, unfortunately. So there was no sustainability, but the pilot did very well. 2 years pilot in these districts, Saiwal and Okada, attached to one medical college, and that improved the situation there, the vaccination rate, the nutrition, which is a problem in children, as Khalid Shafi just highlighted. And these things, our problem is there is too much overcrowding. For example, I have been chief executive of about 12 major hospitals like PIMS. In PIMS, which is a university teaching hospital, we were doing 250 plus deliveries every day. So we are not a maternity home. So that is why I think the people look up to these tertiary care hospitals, because there are non-functional facilities next door. So that they need to be made functional.
Thank you. So 2 minutes में what should we do? क्या करें? 2 चीजें 3 चीजें क्या करें?
I will just add to what Dr. Javed has mentioned. Actually, our priorities should be focused toward the prevention. That is the only way we can get the universal health coverage. And the missing part is that all the attention is on the curative medicine. Even preventive medicine is not much taught as it should be in the undergraduate and the other curriculum. And in the primary healthcare, the missing part is the community engagement. And the community participant is still in the places where it is practiced. The community engagement is not there. In the Azad Jammu Kashmir, the community engagement is so strong that their 85% vaccination is done at the vaccine centers. The community is so bound that they do not miss any vaccination. Their coverage is more than 90%. But in the other parts, it is only 30% vaccine is done at the fixed center, while the vaccinator has to go door to door. So it's a community participation which is an essential part of the PHC.
Right.
It should be promoted. That is the way we can get good results.
Ji, Dr. Sobia, 2 things we can do.
I think the key is the prevention, and we have to start with prevention if we really want to have universal health coverage with PHC. And the prevention has to start from the school-based trainings, nutrition, vaccination, and just from the grassroots level. Secondly, build up on the frontline workers. So we have lady health workers who are generally giving population control advice or gynecological services. They can be upscaled to screening for diabetes, for hypertension, for obesity, because these are the rising threat of non-communicable diseases. Then better data and digital tools. I think it is the area of digitalization, and without electronic records, it's not possible to make our policies. And finally, I would say proper referral between the primary healthcare hospital and the hospitals. That needs to be smooth and recognized.
Ji, thank you so much. Dr. Asif, what 2-3 things we can do?
Ji, I think if you really look at the theory, it is very simple. The problem is implementation. That takes time, money, and all that. So I think यहाँ बैठ के we can say कि ये कर लें, वो कर लें, but I'm afraid it's not going to happen. So I'll give you this simple, actually very straightforward principles, especially on the primary healthcare. And this is what I've basically learned from the WHO and working in the field. So you start at the basics. Our model of care is flawed. We need to develop a multidisciplinary, patient-centered, preventive model of care. Now that's very simple to say, but doing it is very, very difficult.
Chalo.
So a model of care, we need to come up with a model of care which the private and the public sector agrees on and say, okay, this is what we want. Right now we have multiple models of care, and that's not going to work. Second is training is the key. If you have a system and you put in the current nurses and the doctors to run that system, it's not going to work. So you need a very robust, multidisciplinary, competency-based training programs. So it is task-driven. It's not theory-driven. What you need to do, we need to train on that. So, for example, a primary healthcare team, like I mentioned before, needs a doctor, needs a nurse, needs a pharmacist, needs a care manager who manages everything, right? You need a clinic supervisor who does the administrative work. So these are a lot of things that we need to do. So training, I cannot emphasize too much on training.
Okay, thank you, sir.
Second, how do you implement it? Implementation में आपने training दे दी और उनको employee लगा दिया, वो अपनी मर्जी का जो भी करना है. Accountability systems, that has to be there.
Sir.
And उसके बगैर आप quality दे ही नहीं सकते.
Great.
You know,
Thank you so much.
standardize quality of care. You need to audit that. You need to monitor it. If someone's not following it, they have to follow it.
Thank you so
Right?
much. Ji.
Implementation. The other simple things is WHO has actually told us how to do it. So there are 10 operation levers of a primary healthcare center. You can just adopt that and implement it, and they're telling you how to do it.
Sure.
Right.
Sure.
So the solutions are there. We just need to get on
Easy
it.
to implement.
Right.
Ji, thank you so much, sir. Dr. Javed Saab, just 2-3 things that we can do, and then we'll wrap up this session.
Thank you. I have more thing to offer, obviously, because since I am dealing with the PHC, and mainly all have been touched upon by my senior colleagues. Very importantly, increase budgeting towards PHC, as was mentioned by Dr. Khalid, because to prioritize PHC, the percentage of budget has to be increased. Infrastructure development, obviously, we are still lagging in the infrastructure. We don't have updated infrastructure who cater to the needs of modern the PHC demands. HR strengthening, very important. Dr. Asif Saab has mentioned that training is very important, because without strengthened HR, we can't do it, and we have to incentivize, as has been said by Dr. Javed. What PPSHA has been doing, like we have introduced third allowance at Tharparkar district, which is a very
It's 2 p.m.
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
Healthcare Expo and Conference लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है. अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए.
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zuhair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
ये सिर्फ एक नुमाइश या एग्जीबिशन नहीं है, ये एक सोच है, ये एक सफ़र है जिसकी बुनियाद डाली जा रही है. और हेल्थ केयर एक ऐसा सब्जेक्ट है कि इसको समझने की और इस पर अमल करने की ज़रूरत है. तो मैं ज़ुहैर नसीर साहब आपको और आपकी टीम को बदर सॉल्यूशन को खराज तहसीन पेश करता हूँ.
Assalamu alaikum ji. I'm really grateful to the organizers for having this very important session on patient safety. Something which is very close to the heart of everyone who is concerned with medicine, deals with medicine, either in the form of a professional doctor, a medical professionalist, or regulatory bodies like DRAP, or those who are in the process of making medicines like from the pharmaceutical country. So, very important factor which involves all of us equally. So, patient safety is one thing that we feel, and I personally feel, is not given that much significance and importance in our country as it has been given to anywhere else in the world. So, at times, I myself being a practicing surgeon, I know when I was working at the JPMC Jinnah Hospital, or later on I'm working in the private sector now, that patient safety does not come as one thing that we should be taking care of as the first step. And that is what we want our new generation of doctors who are coming up, that they should be aware of that. So a panel which represents almost everyone from physician, Aftab Sahab, from surgeons, to those who are in regulatory bodies, from PharmU, and those also who are from the hospital side, like Nashwa is from the South City Hospital. So let's start. I'll start you, sir, Aftab Sahab. What structure and cognitive factors most commonly contribute to the diagnostic errors that we make? And there are a number of diagnostic errors we all know. And how can healthcare team, not an individual, proactively mitigate them? What do you think? What do you think how it could be done?
I think the first thing to do would be to define diagnostic error for the sake of the public. And diagnostic error means when you cannot make the right diagnosis, or you miss the right diagnosis, or even if a diagnosis is delayed, that is also called a diagnostic error. And if even the diagnosis is correctly made, is made in time, and is not communicated to the patient in time, even that is a diagnostic error. So in US, about 12 million diagnostic errors took place 2 years ago in 1 year. And they were responsible for a number of deaths. Diagnostic errors, they come under the ambit of medical errors. And the medical errors were first highlighted in a report of Institute of Medicine, which was published in 1999. So, I personally believe that these occur because we do not do what Sir William Osler asked the modern day physician to do. And he was a professor at University of Pennsylvania in 1905, beginning of the last century. And he said, listen to your patient. He is telling you the diagnosis. So unfortunately, we are more focused on clinical decision support systems and artificial intelligence, whereas in many prospective studies we know that the correct diagnosis can be made in about 75% cases on history alone, 6 to 7% on examination, and 13-14% on investigations. So if we employ the right history, spend quality time with the patient, examine, and become a thinking doctor. One important thing is, as we become senior, we stop at times to think and do things reflexly. And that contributes to diagnostic errors. Once the diagnosis is incorrect, then it erodes the trust. It jeopardizes the outcome of the patient. It causes extra burden on the cost. Medical errors, sir, are responsible for an additional cost on healthcare of $50 billion per year. So this is all preventable if we start with the right history, spend time with the patient, and if we have systems in place. Unfortunately, when we are overburdened with patients, we do not have systems. So first is the cognitive problem, that the physician herself or himself is at fault. Then are the systems. अब वो हमें कहते हैं कि जी EMR इलेक्ट्रॉनिक मेडिकल रिकॉर्ड होना चाहिए। आप बड़े बड़े ओहदों पर रहे हैं माशाल्लाह, and you have headed so many institutions, and now you are at the helm of the policy making in the province of Sindh, and with the status of a minister. So you should know that these doctors, EMR requires time. If you go to US and UK, a doctor is supposed to see only a maximum number of 10 to 12 patients in one day, because it takes 30 minutes to register the patient on EMR. तो एक तरफ एक्सपेक्टेशन है कि EMR हो, दूसरी तरफ नंबर ऑफ पेशेंट ज्यादा है। फिर हम जब मांगते हैं एज अ फिजिशियन सर, वी आस्क फॉर डेटा एंट्री ऑपरेटर, तो वो कहते हैं नहीं ये आपने खुद करना है। तो बड़ी ही एक डायलेमा है। फिर दो चीजें और हैं, विद परमिशन ऑफ द चेयर आई वुड लाइक टू हाईलाइट, जो डायग्नोस्टिक एरर में सिग्निफिकेंटली कंट्रीब्यूट करती है। एक है हेल्थ डिस्पैरिटीज, और आपसे ज्यादा कौन अवेयर होगा कि जब मरीज आता है हॉस्पिटल में, तो वो लोग जिनको सबसे ज्यादा जरूरत होती है केयर की, दे एंड अप रिसीविंग द लीस्ट केयर। आई विल हाईलाइट few example. People who inject drugs, doctors, most of them look down upon them, ऐसे जैसे वो कोई जुर्म करके आ रहा है। वो तो बेचारा ड्रग एडिक्ट अपनी मर्जी से नहीं हुआ है, वो तो आपकी शफकत और मोहब्बत चाह रहा है। People who are left unattended, people who are poor and marginalized, people who are mentally challenged, people who are old and who have multi-morbidity, ये सारों को ज्यादा जरूरत है, और प्रिजनर्स, लेकिन इनको कम मिलता है। तो एक ये भी वजह है डायग्नोस्टिक एरर्स की और मेडिकल एरर की। और सर एक और वजह है, वो है ये सिस्टम कोई इंसेंटिवाइज नहीं करता। या कोई अच्छा काम कर रहा है या बुरा काम कर रहा है, वो सबके लिए बराबर है।
डॉक्टर नवीद, कंटिन्यूइंग विद व्हाट आफ्ताब सर ने बताया इन अ वेरी वेरी नाइस elaborative way what errors are. Don't you think, as he has said, that right now we are emphasizing more on the diagnostic tools rather than applying our knowledge of medicine in the form of history taking, examination, which our professors used to emphasize a lot. And they were of the view that, as he has very correctly said, that majority of the diagnoses are made on that. Today, हम या हमारे साथ जो लोग हैं, because of the availability of CT scan, MRI, so many things, the first thing we do when the patient comes is, for example, a headache, MRI karakia. Now, taking an easy way out to diagnose, because we have got so much rush, we don't want to examine him properly for that. आप क्या समझते हैं, does it contributing to diagnostic error, and how can it be overcome?
Sir, thank you very much for giving me a chance to collaborate myself on such an important topic. So you are very right, sir. Said a very important sentence in the beginning that listen to the patient, he is telling you the diagnosis. So I personally feel that one factor is the patient's workload, because a doctor has to see a lot of patients in 3 to 4 hours, and the patient expects that the doctor should not only listen to him or her, he should also examine her and him and then prescribe the relevant investigation. But I personally feel, sir, keeping in view all these limitations, they are there, but one link is definitely missing, and that is we do not touch our patient. That sense of touch, like we talk of the sense of touch between the mom and the baby, exactly the same relation exists between the patient and the doctor. This link is missing, and how we can re-establish this link, I don't know, because the patient to doctor number is too much. But I personally believe that this factor should be addressed seriously, and this should not only develop the patient-doctor, strengthen the patient-doctor relation, but it also decrease the workload on our investigations. Like, number one, the patient expects a doctor साहब को test ही लिखा, so doctor writes the whole battery of the investigation, including chemistry and radiology and everything. But if we start doing that, and if we start developing the rapport with the patient in terms of detailed history and clinical examination, and then full explanation to the patient, because once the patient leaves the patient, office of the clinician, he's I don't know, मुझे तो नहीं पता डॉक्टर साहब ने कि मुझे क्या मसला है. So we should properly explain the patient, and it would definitely decrease the workload on our investigation to better investigation. As sir mentioned, I was reading a few days back, because it would also jeopardize the number of patients. It would also jeopardize the patient safety as well, which is our prime topic today. And recently I was reading an article in which it was mentioned that the number of deaths in USA, because USA and UK, they are the icons for us. We read the books written by their doctors, and it counts around 2 lakh a year because of the breach in the patient safety chain. And number two example of UK, the NHS budget rose almost to 40% in the last 1 to 2 years. So I personally believe, sir, highlighting the very true topic of this age, the number of patients is the main cause that are diagnostic battery of investigation is rising, and we are missing the link between the patient and doctor because we cannot explain to him, we cannot examine to him.
Samad Sahab, ये बताएं कि because you are in digital, which is the latest thing like AI and other things the companies, do you have any solution for the problem that has been raised for overcoming these diagnostic errors? Do you have that? Not only relying upon the diagnostic tool, because once the tool goes wrong, the whole management will go wrong. So, do you think that the recent trends that you are just talking about, bringing up together, can they be of any support in overcoming this decision making of a diagnostic tool not to go wrong?
Assalamu alaikum. Thank you so much, sir. First of all, we at Digitrends currently working on the AI solutions which we think can make a difference in patient safety. I will give you for example which I think is relevant, how AI and IT can make a big impact on patient safety. First of all, we are going to integrate it with our EMR solution. So currently in the conventional EMR, if doctor enter the wrong medicine, or if any medicine which is not suitable for the patient, he has the allergies or some kind of histories, doctor cannot go through all the EMR details every time, and he can enter wrongly some medicine which may affect the health of the patient. Our AI system can be integrated with the EMR, and it can, in the real time, stop the doctor that do not enter that kind of medication that can be harmful for the patient. This is the one example, and there are many other features which can be very helpful when AI will be integrated into the current AMR solution. The second example would be, we are currently working on the world first FDA-approved wearable ECG device. So currently what is happening, when the device is taking the ECG of the patient, it is transmitting the data to the mobile application, and that mobile application submitting that data to the doctor, who is actually manually reading the ECG, and then he is diagnosing and prescribing the medication over his whatever he sees over his diagnosis. Now, if we integrate AI into that in between, where doctor is currently diagnosing or checking the ECG, the AI system can do this automatically, and he can suggest, the AI can suggest either the patient needs immediate attention of the doctor, so it can send the ambulance, or through telemedicine, doctor can connect to the patient directly. So if we will integrate AI agents into this hardware monitoring system, healthcare hardware monitoring system with the patient and doctor, that AI can do the job of the doctor, the initial job of the doctor. So it can be make great impact as well. The third thing is that differential diagnosis tool. We are partnered with the leading differential diagnosis tools such as Visual DX. So we integrated that Visual Diagnosis. We launched that differential diagnosis tool here in Pakistan, We saw a very good adaptation on AI on that tool. If you take a picture of your skin region, the AI image recognition system can recognize either it's psoriasis or eczema through the thousands of images which is already stored in the database of the AI. And doctor who may know, maybe he cannot diagnose that this is the early stage of psoriasis, AI can detect it in a very early stage. So these are the 3-4 examples which I think, and this is already happening in the world. AI has been integrated. The question is, we are not only trying to implement and integrate these solutions currently within this Pakistan market and in Saudi and in Dubai. We are also taking care how the AI governance and how AI compliances can be a part of it. So it can be implemented. Again, it's related to patient safety also. So I think AI will make a great impact, inshallah.
Thank you. Dr. Mema, my question to you, because you're also associated with the pharmaceutical, what prescribing safeguards are there for effective avoiding any prescribing liquidity or anything that can be a wrong prescription because you're associated with the pharmaceutical? What safeguard the pharmaceutical has done to them? For example, I can give you a number of medicines with a similar name, similar appearance. In cases of an emergency, sometimes the does pick up the wrong one, and it may be illegal for the patient. So, what are the safeguards that the pharmaceuticals taking in order to avoid these prescribing?
All right. Thank you so much. My name is Umema. Thank you for inviting. I'm representing a pharmaceutical company here, but I also hold a position for a primary healthcare setup here in Karachi. So I have kind of an ambit or a cap of both, say it from a pharmaceutical perspective and from the hospital end as well. And there have been a lot of solutions that आपने AI की बात करी, and there are a lot of integrations. And same goes when it comes to patient safety, and we talk about what systems can be implemented in pharmaceutical companies. But before I can actually talk about what should be done, I'll be talking about a patient safety culture. And there is a small presentation, if you may all allow me to give a small presentation of the magnitude of patient safety which we are talking about, especially here in Pakistan. So, sir, if you may allow, I'll just give a brief presentation. It's hardly of 10, 11 slides.
So we can just discuss that now. We can give us a brief description about that.
I'm sorry?
We are running short of time, so...
Okay. All right. So I'll just make it very precise. See, for me, when it comes to ADR or pharmacovigilance, or we talk about reporting system, the first thing which has to come is to start reporting. We do not hold here a culture of reporting. DRAP already has established systems in which the healthcare providers and the people who are in the pharmaceutical companies are encouraged to report any ADR which is reported. And I'm talking about the drug reporting errors. I'm not talking about the medical errors, just Dr. Saab ne initially kaha that also comes under the ambit of medical error. But unless and until we do not know what is being reported and what are the root causes of it, how are we going to actually establish systems in our areas to counter that? And I'm sorry, I was not able to listen to your specific questions regarding pharmacovigilance.
Regarding the drug we use, for example, recently, DRAP has withdrawn a syrup because it was causing a lot of complications. Many medicines are withdrawn. So what pharmaceutical industry is taking care of avoiding those errors to take place when you are manufacturing a medicine? What are the protocols that you follow? Are there any protocols?
Yes, definitely. See, pharmaceutical companies, especially in Pakistan, I would consider this is the most regulated industry in Pakistan. And it has federal regulations applying to it as well as the provincial ones. So there are systems established. Say, for example, I'd give, an example of LASA, which is called as the lookalike enzyme villi, which is the major, one of the major causes of, wrong administration or wrong prescribing. And there is a whole system established by pharmaceutical companies, especially the MNCs as well as the local pharmaceutical companies, they have established systems in which they do have protocols, and especially with the integration of AI into such systems, we are able to check that. And similarly goes with the names. But unfortunately, I would refer to the recent cases of Avastin, as we all are well aware. The case of ceftriaxone, we already know that. But these were malpractices of administration rather than something which was falling under the pharmaceutical category. So the indications are, of course, devised.
Thank you very much. Nashwa, you are related to a hospital, a major hospital in the city. So what do you think in a hospital? We all know there are so many cases reported, so many errors take place. We wait time and time to the patient. Patients have lost life. So do you think what are the major protocols that could be applied, or what are the systems that need to be in place in order to avoid all that what is unfortunately happening if patients are being mistreated or being misdiagnosed or whatever you say, which is harmful to the patient whenever they come to the hospital? Any protocols or systems that you think are there, or you will suggest them to be applied?
Ji, Assalamualaikum. Thank you, sir, for having us. Thank you for having us. So I work very closely with a lot of workflows with different kinds of healthcare providers, be them physicians or nurses. Now, in terms of reducing harm, there are different components to how you can reduce harm based on who the provider is. जैसे हमने आज की discussion में देखा है, the physician's perspective or the surgeon's perspective is very unique and different. They have different goals for the patient, be it their assessment, their diagnostics, the treatment plan. That is a vision which is dedicated to the physician. Where safety falls in, where measures fall in, where systems fall in to reduce harm in that pathway is separate. That is something that is addressed separately, that has different patterns, different safety measures. If we're talking about surgery, for example, something which may seem like a very simple process, but starting from when the moment the patient arrives in your clinic, what is being communicated, what is being documented, what is going on the record, what does the patient understand from everything the surgeon is saying? And in the event of a harm happening, was that harm pre-warned, pre-informed to the patient? Was it uninformed to the patient? What are accountability measures in place for the surgeon or for the providers? So, surgeons, for example, nursing is a completely different game. Nursing ka role is absolutely separate. They are more involved with the hands-on care of the patient in a time which is vaster than it is for the physician. How to reduce patient falls, how to prevent the patient from getting harm from regular activities while they're in the hospital setting, during mobilization, during eating, to prevent aspiration, for example, to prevent medication errors. What is the process of the medication cycle? उसके हमने कौन से metrics, accountability tools रखे हैं to make sure medication is being given safely?
Also, being a physician, there are a number of times we are prescribing a medicine. A patient has got a problem. He says, for example, full factor deficiency, yeah, I've got epilepsy. And when we are prescribing a medicine for that, not for that, for other reasons, we at times do not know whether this medicine will be harmful to that or is contraindicated to that. So at times we miss, because no doctor can have knowledge about every disease and what medicines they are indicated. Do you think the use of e-prescription could be effective in that, or still the use of our own intelligence in that will be more effective?
I think, sir, you have rightly pointed out electronic medical record or e-prescription can help reduce it, magar it cannot eliminate it. Healthcare industry is supposed to be an industry which is far less regulated than many other industries like flying industry. People who are flying jets and airlines, they are far more meticulous in their approach, whereas the number of people suffering at the hands of medical error is far more. In USA alone, medical errors have become the third leading cause of death of them, there are 250,000 every year, half of them are preventable. And sir, 250,000 makes it about 680 per day. That is like 1.5 jumbo jet going down every day. And look at the time, look at the method, look at the money that is being spent on airline safety compared to healthcare safety in our profession. So something we are doing is absolutely wrong, and it requires a paradigm shift.
So what do you suggest? Like, as we have very correctly said, there are a number of prescribing errors that we are making. Even the most senior ones make an error in prescription, and they miss on the history of the patient because EMR is very good, it's a new thing. But practically speaking, as we have been working in a government sector hospital, the prescription when you write a government sector hospital in an OPD with 300 patients standing and you have to pass within 3 to 4 hours, it's not possible to go for an EMR for each one of them. Either it should be a limited number of patients that you have seen, but you are seeing an uncounted number of patients. उस कंडीशन के अंदर what do you suggest, what protocol or what safety measures could be undertaken कि आप either it should be at the end of the prescribing doctor or the pharmacy which is issuing should take care of that when the pharmaceutical after prescription जाए that this drug should not be given to this patient or the dosage is not correct. What do you think? How could it be counteracted?
I think, sir, you have highlighted the issue in your own question that it cannot be anyone working in isolation. What we are doing right now is working in silos. Physician working as a physician, pharmacist working there. EMR, I don't think is going to be the solution in Pakistan. There are two things. I am an old school. I believe that if you spend quality time with the patient, that not only builds trust, it also ensures patient safety and it also ensures quality care to the patient. But at the same time, we have to think differently. The money cannot go to the armed forces of Pakistan and our patients deprived of their due rights. ये कहाँ पर होता है कि 1% GDP से भी कम हम एजुकेशन और 1% से कम हेल्थ पे खर्च कर रहे हैं. This thing will have to change if you want to change or contribute. अमेरिका में वो कहते हैं कि हम 2,50,000 लोग हमारे मरते हैं हर साल और वो कहते हैं कि 3 मिलियन लोग मरते हैं दुनिया में हर साल. पाकिस्तान में तो रिपोर्ट ही नहीं होती. इंडिया में 54 million medical errors take place every year, which is among us. So हमारे तो वो figures ही नहीं है. So we have to bring in more money, we have to bring in more resources. और वो पाकिस्तान के कहाँ से आएंगे? डेट सर्विसिंग से आएंगे, आर्म फोर्सेस से लेंगे. ये अभी बात हो रही थी सर कि प्राइमरी हेल्थ केयर पे पैसा नहीं लगाते और इंडस को 10 बिलियन दे दिया. भाई इंडस को 10 नहीं 20 चाहिए, मगर ये नहीं है कि वो ये समझते हैं कि इंडस से लेके नहीं लगाया जा सकता. इंडस को पहले ही ज्यादा चाहिए, आपको मजीद पैसा चाहिए और उसको लाना पड़ेगा in order to improve the health. और EMR is not the solution, sir.
So what we conclude is that though these gadgets are very good, the EMR or the digitalization that Africa, but it is not this case you can have a blanket thing from the US coming to Pakistan and make it. We have to cut it according to our own needs and our own requirements and our own problems that we have. सबसे बड़ा इशू ये कि you don't have that much of resources available. जैसे कि रोबोटिक के बाद सिंध में एक बड़ा हंगामा हुआ 2025 whether to buy a robot or not to buy a robot, costing billions of rupees. Whether that should be spent on a robot to be bought or that should be spent on primary health care. Because tertiary health care is given more emphasis upon in every part of Pakistan rather than the primary health care. जबकि दुनिया भर में मतलब प्राइमरी हेल्थ केयर ज़्यादा करें ताकि आपको पेशेंट ही ना है. क्लीन वाटर नहीं है आपके पास, इम्यूनाइजेशन की कमी है, and they all better. मैं नवीद साहब आपसे पूछूंगा, being a surgeon, we make a lot of errors. I am a surgeon myself. Sir. What checklist, team communication strategies, or data tools you will suggest that can avoid those errors that we make during our surgery?
Sir, so this is a very important topic, and I think this is all we being clinicians are meant for. The patient safety first. And these all checklists, they are meant for this purpose. There are many checklists, sir. First is a WHO checklist, and second is SURPASS checklist. Surgical patients safety factors. But sir, I personally believe before we go to the fancy checklist, we need to educate our healthcare providers. And actually, sir, we start with the top-down approach: consultants, and then senior residents, and then junior residents, and actually. The main stakeholders, in my opinion, they are the nursing staff. You may agree or not that most of the time spent with the patient is by the nursing staff. So checklists are there, sir. Definitely, like WHO checklist. WHO checklist, sir, is basically is meant for mainly in the operating room, before induction and before NCM and before the patient leaves the operating room. It mainly encompasses all that horizon while the patient is inside the operating room. Actually, sir, the safety starts right from the clinic of the clinician. When the patient visits the clinic of the clinician, the safety measures need to be adapted. In the case of preoperative care and then followed by intraoperative and then postoperative care. And the whole scenario is encompassed by the one term that is called these days as perioperative care. Sir. So in my opinion, in preoperative care, we should emphasize on detailed history. Actually, sir, I would conclude in one line: go back to the basics. Actually, sir, we have left the basics, and we have done like sir said, like electronic medical records and like EMS system and EMR system, everything. It looks very fancy. It fantasizes someone. We are like advancing in every field, but we have no money with us. So we will have to go back to the basics. We will need to take the detailed history and examine the patient and then assess the comorbids and do a detailed and good pre-anesthesia assessment before the patient is subjected to surgery. And likewise, while the patient is in the ward the night before the surgery, I personally believe no doctor goes to the patient to document the things like which side is to be operated upon, whether it is right side or left side, where the stoma is supposed to be formed. This is done by nursing staff. Like, and the consent form is put in front of the patient. Please just sign kar dein. What is written in that consent form? Neither the staff nor the patient and nor the tenders don't know anything. So, sir, in my opinion, these checklists, they are very good. But after once we have done our homework, we have taught our basic stakeholders in the wards, in the hospitals, in the OPDs, and then, sir, in the operating room, mainly WHO checklist. Definitely, if it is emphasized in true letter and spirit, it can avoid so many avoidable medical accidents, right, sir? And then, obviously, post-operatively, in the theater, the main stakeholders are an anesthetist and then followed by the surgeon. And then post-operatively, again, the surgeon operates and he endorses the notes, and the whole night we should spend with the nursing staff. And the nursing staff, the ratio must be 60:1 or maybe 60:2. And I think, sir, basic homework needs to be improved.
बिस्मिल्लाहिर्रहमानिर्रहीम। मोहम्मद अली मलकानी साहब, मिनिस्टर लाइफ स्टॉक एंड फिशरीज, जुल्फ़िकार अली शाह साहब, मिनिस्टर कल्चर एंड टूरिज़म, हमारे बलूचिस्तान से आए हुए मिनिस्टर लाइफ स्टॉक सरदारज़ादा फैसल ख़ान और मिनिस्टर फिशरीज़ मीर बरकत रिंद साहब, यहाँ पे बैठे हुए स्टेज पे और मौज़ीन, स्पेशल असिस्टेंट्स, मेरे MPAs, डिप्लोमेटिक कोर्स से आए हुए हमारे मेहमान, डेल्फा के हारिस अली मिठानी साहब, ख़वातीन व हज़रात, अस्सलाम वालेकुम। میرے لیے یہ نہایتی باعث افتخار ہے کہ آج یہ لائف اسٹاک اینڈ فشریز ڈپارٹمنٹ اور ڈیلفا کے اشتراک سے جو لائف اسٹاک کیٹل اور فشریز کا ایکسپو ہو رہا ہے کراچی میں، اس کا افتتاح میں نے آج کیا ہے. یہ ایک موقع ہے ان سارے لوگوں کے لیے جو لائف اسٹاک فشریز کیٹل کے کاروبار یا اس کے شوق رکھنے والے ہیں، اس سے منسلک ہیں، وہ سب جمع ہوں، وہ دیکھیں کہ کیا ریسرچ ہو رہی ہے، پبلک سیکٹر اور پرائیویٹ سیکٹر آپس میں ملیں، آپس میں نالج شیئر کریں اور اس سیکٹر کو مزید ترقی دیں جس کا پوٹینشیل آپ کو منسٹر صاحب نے بھی بتایا، ہمارے منسٹر لائف اسٹاک بلوچستان، منسٹر فشریز بلوچستان نے بھی بتایا، آپ کو ڈپارٹمنٹ کی طرف سے بھی بریفنگ کی گئی کہ اس کا پوٹینشیل جو اس وقت بھی ایگریکلچر سیکٹر کا 64% ہے، لیکن ہمارا ٹوٹل ایگریکلچر سیکٹر اور لائف اسٹاک سیکٹر کا جو پوٹینشیل ہے اس کا ہم صرف انگریزی میں کہتے ہیں جسٹ اسکریچنگ دا سرفیس. ہمیں نہ صرف اپنی فوڈ سیکیورٹی کے لیے بلکہ اس ملک سے ایکسپورٹس کو بڑھانے کے لیے دونوں ایگریکلچر اور لائف اسٹاک میں اور فشریز میں اتنے زیادہ مواقع ہیں، اور اس کے لیے حکومت سندھ اپنی کوشش کری ہے. جیسے آپ کو بتایا تھا ڈپارٹمنٹ کی پریزنٹیشن اور بریفنگ میں، ہم نے، اور آپ جب وزٹ کریں گے سٹالز کو تو آپ دیکھیں گے کہ لائف اسٹاک ڈپارٹمنٹ نے ہمارا یہاں کورنگی میں پورا ایک سینٹر ہے جس میں ہم نے ایکسپینشنز پچھلے کچھ سالوں میں کی ہیں. اب ہم وہ ویکسینز جو باہر سے امپورٹ کیا کرتے تھے وہ تقریباً 10 سے 15% جو ہماری کاسٹ آ رہی تھی امپورٹ کرنے کی، اس پہ وہی ویکسینز بنا رہے ہیں. اور اس سے انشاءاللہ تعالی پرائیویٹ سیکٹر میں جو لوگ اس کاروبار سے منسلک ہیں، ہمارے جو فارمرز ہیں، ان کو فائدہ ہوگا. اس کے ساتھ ساتھ پیداوار بڑھانے کے لیے جو طریقہ کار ہیں اس پہ بھی ڈپارٹمنٹ کام کر رہا ہے. فشریز کا جو پوٹینشیل ہے، ہمارے پاس 400 کلومیٹر سے زیادہ کوسٹ لائن موجود ہے. اس کے علاوہ انلینڈ فشریز کے بہترین مواقع ہیں. کل یا پرسوں میٹنگ کر رہے تھے چیئرمین بلاول بھٹو زرداری صاحب کے ساتھ، تو انہوں نے ہمیں بتایا گیا کہ ہمارا انویسٹمنٹ ڈپارٹمنٹ، ادھر SCDF کا اسٹال بھی تھا، وہ شرمپ فارمنگ کے لیے لوگوں کو سپورٹ کر رہا ہے. جو شرمپ فارمنگ کا پوٹینشیل ہے وہ بھی بے تحاشا ہے. ہمارے ملک کو اس وقت اپنا زرعی مبادلہ بڑھانے کے لیے، ایکسپورٹس کو پروموٹ کرنے کے لیے بہت زیادہ ضرورت ہے، اور پوٹینشیل ہمارے یہاں ہی موجود ہے. ہمیں کسی اور کو باہر دیکھنے کی ضرورت نہیں. اس وقت تو ہم وہ جو IMF کی کنڈیشنالٹیز میں ہیں یا ان کے پروگرام میں ہیں، اگر ہم سب اکٹھے ہو جائیں، اگر ہم اس ملک کی جو یوتھ ہے اس کو گینفل امپلائمنٹ دے سکیں. اور اس وقت میں بتا سکتا ہوں آپ کو کہ یہ ایگریکلچر سیکٹر میں، جس میں لائف اسٹاک بھی آتا ہے، فشریز بھی آتا ہے، جو اپرچونٹیز ہیں اس کو اگر ہم صحیح استعمال کر سکیں تو انشاءاللہ تعالی ہم ان پروگرام سے بھی نکل جائیں گے IMF کے، ہماری ایکسپورٹس بھی بڑھے گی. ہم انڈسٹریز کے لیے جو را مٹیریل ہے وہ بھی ادھر سارا پیدا کر سکتے ہیں. تو ہم سب نے مل کے یہی کرنا. اور یہ جو آپ کا ایکسپو ہے کیٹل اینڈ لائف اسٹاک اور فشریز کا، یہ ایک موقع ہے کہ اس سیکٹر سے منسلک سارے لوگ اکٹھے ہوں اور ملک کی بہتری کے لیے ہماری اکنامک کنڈیشنز کو بہتر کرنے کے لیے کام کریں. میں لائف اسٹاک اینڈ فشریز ڈپارٹمنٹ کا شکر گزار ہوں, انہوں نے اس کا انتظام کیا. میں ڈیلفا جو ڈیری اینڈ لائف اسٹاک فارمرز ایسوسیشن ہے ان کا بھی شکر گزار ہوں, انہوں نے تعاون کیا, اور انشاءاللہ تعالی ہم مل کے اس سیکٹر میں مزید ترقی کریں گے, اور مزید کیا بہت زیادہ, اس لیے کہ پوٹینشیل جو ہمارا ہے اس کو ہم نے ابھی تک صرف چھوا ہے. یہ ہمارا ملک ہسٹوریکلی ایگریکلچر کنٹری ہے. ہمارے سندھ کے اندر جو بلوچستان سے بارڈر ملتا ہے, جو پہاڑی علاقہ ہے, ہمارا بالکوستان کا علاقہ, آگے جو ہماری کیرتھر رینج ہے, وہاں پہ کیٹل بریڈنگ کے اتنے مواقع ہیں, اور اسی طریقے سے بلوچستان میں. پھر ہمارا جو ایسٹرن بارڈر ہے, تھرپارکر ڈسٹرکٹ مشہور ہے اپنی لائف سٹاک کے لیے اور کیٹل کے لیے. ان دونوں جگہوں پہ خاص طور پہ ہم نے لوکل لوگوں کی روزگار کو بہتر کرنے کے لیے اور پروگرامز کرنے. میں دعوت دوں گا, اس لیے کہ یہ کراچی میں ایونٹ ہو رہا ہے. میں چاہوں گا اور میں آپ کے توسط سے اور میڈیا کے توسط سے لوگوں سے کہوں گا, خاص طور پہ جو بزنس کمیونٹی ہے وہ آئیں اور وہ دیکھیں جو اپرچونٹی ہے ادھر ہمارے پاس لائف سٹاک کے اندر, فشریز کے اندر. اور انشاءاللہ تعالی جو ہمارا جیسے بتایا بھی گیا تھا پبلک پرائیویٹ پارٹنرشپ کا پروگرام ہے, سیکرٹری صاحب نے اس کا ذکر کیا تھا, اس کے اندر ہم نے انفراسٹرکچر میں, سروس سیکٹر میں بہت کام کیا ہے. لیکن اب چیئرمین بلاول بھٹو زرداری صاحب کہ یہ فوکس ہے کہ وہ ایگریکلچر میں بھی پبلک پرائیویٹ پارٹنرشپ کے اندر کام کریں, اور اس سلسلے میں جلد ہی ہم انویل کریں گے. ہمارے جو ایگریکلچر ڈپارٹمنٹ کے فارمز ہیں, ہمارے لائف سٹاک کے فارمز ہیں بہت زیادہ پورے صوبے میں, جس میں اسپیشلائزڈ جو نسلیں ہیں ان کی افزائش ہوتی ہے. ہم چاہیں گے کہ پرائیویٹ سیکٹر ہمارے ساتھ آئے اور ان جو فارمز ہیں ہمارے ان کو ماڈرن لائنز پہ باہر سے ٹیکنالوجی لا کے چائنا کے ساتھ ہماری بہت زیادہ, بلکہ آج سے 10 سال پہلے, بلکہ اور بھی زیادہ 12 سال پہلے, میں خود اس وقت صدر آصف علی زرداری صاحب کے ساتھ جب چائنا گیا تھا تو ہم نے فشنگ کے لیے ایک ایم او یو سائن کیا تھا, لیکن انفارچونیٹلی اس کو ہم آگے نہیں بڑھا سکے. اب موقع ہے, زرداری صاحب پریزیڈنٹ صاحب پھر اگلے مہینے چائنا کا دورہ کر رہے ہیں, اور میں چاہوں گا کہ ہمارا لائف سٹاک ڈپارٹمنٹ, فشریز ڈپارٹمنٹ جو پرانے ایم او یو سائن کیے ہوئے ہیں, ایگریکلچر ڈپارٹمنٹ ادھر منسٹر صاحب نہیں ہیں لیکن سیکرٹری موجود ہیں, ایگریکلچر ڈپارٹمنٹ شوگر کین کے لیے ہمارے پرانے ایم او یو سائن ہیں چائنا کے ساتھ, ہمارے رائس کے لیے, پیڈی کے لیے ایم او یو سائن ہے, اسی طریقے سے شرمپ جو فش فارمنگ کا تو مجھے بھی یاد ہے, میں خود موجود تھا اس ایونٹ پہ جب وہ سائن ہوا تھا. یہ پرانے ایم او یوز نکالیں, ان کی تیاری کریں. پریزیڈنٹ صاحب جب اگلے مہینے جائیں چائنا تو ہم ان کو ریوائیو کرنے اور ان ایم او یوز پہ ان کو امپلیمنٹ کرنے کے لیے ہم کام کریں. تو یہ میرا میسج ہوگا اس پروگرام کے حوالے سے کہ کراچی میں بزنس کمیونٹی بھی اس اپرچونٹی کو آگے دیکھے, ہمارے ڈپارٹمنٹس بھی جو ایک لیگ آ گیا ہے, ہم نے کوشش کرتے ہیں لیکن جتنا پوٹینشیل ہے اتنا کام ہم نہیں کر رہے ہیں. تو ہمارے ڈپارٹمنٹس بھی خاص طور پہ ایگریکلچر, لائف سٹاک اینڈ فشریز, یہ تینوں کا آج یہ جو یہ ایکسپو ہے اس میں تینوں کی نمائندگی ہے, ان کے آگے بڑھنا چاہیے اور لوگوں کو مزید فیسیلیٹیٹ کرنا چاہیے, مزید وہ انوائرمنٹ پیدا کرنی چاہیے کہ پرائیویٹ سیکٹر اس میں زیادہ سے زیادہ انویسٹ کرے. اس کے ساتھ ساتھ میں کلچر منسٹری اور کلچر منسٹر کا بھی شکر گزار ہوں کہ انہوں نے بھی یہاں پہ اپنا حصہ ڈالا ہے اس ایکسپو سینٹر میں, اور انشاءاللہ تعالی یہ جو 3 دن 17, 18, 19 جنوری یہ ایونٹ یہاں پہ رہے گا, یہ کامیاب ہوگا. اور اس کے جو مقاصد ہیں کہ ہم ایگریکلچر سیکٹر, لائف سٹاک اور فشری سیکٹر کو مزید پروموٹ کریں, وہ آبجیکٹیوز وہ ہم اچیو کریں گے. آپ سب کا بہت بہت شکریہ جو آپ یہاں تشریف لائے، اور میں ایک بار پھر ڈپارٹمنٹ کا شکر گزار ہوں کہ انہوں نے مجھے تو بلایا. آپ کا شکریہ. پاکستان زندہ باد.
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
हेल्थ केयर एक्सपॉइंट कॉन्फ्रेंस लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है. अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए.
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zuhair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
یہ صرف ایک نمائش یا ایگزیبیشن نہیں ہے، یہ ایک سوچ ہے، یہ ایک سفر ہے جس کی بنیاد ڈالی جا رہی ہے. اور ہیلتھ کیئر ایک ایسا سبجیکٹ ہے کہ اس کو سمجھنے کی اور اس پر عمل کرنے کی ضرورت ہے. تو میں زہیر نصیر صاحب آپ کو اور آپ کی ٹیم کو بدر سولوشن کو خراج تحسین پیش کرتا ہوں.
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
हेल्थ एक्सपो एंड कॉन्फ्रेंस लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है. अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए.
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zuhair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
ये सिर्फ एक नुमाइश